so much. So we shall now move on to the next session in drug reviews and therapeutics. And for this, we have with us Dr. Nilakshi Deka. So Dr. Nilakshi Deka is a consultant endocrinologist in Guwahati and is associated with the International Hospital and the Dispur Polyclinic and Nursing Home. And she has also been a visiting consultant to Excel Care Hospital. And she's had wide experience in managing patients with type 1 and type 2 diabetes, obesity, and metabolic disorders. And she also has an avid interest in areas of thyroid, pituitary, and adrenal disorders. Dr. Nilakshi is going to talk to us about gliptinization, how the roadblocks can be addressed. So over to you, Dr. Nilakshi.
Thank you, Dr. Neeta Deshpande, for that wonderful introduction. In order to be more frugal on the net connection, which is quite erratic in my place, I would like to switch off my video while presenting the session, if that is not a problem.
Absolutely.
Thank you so much. I'll be sharing my slides now. I hope my slides are visible to everyone.
Yes, yes, it's visible.
So this is a very interesting topic which I have been given to speak on, gliptinization, addressing the roadblocks. So gliptins have been with us since a decade, maybe now, more than a decade actually. So it's a molecule we are well versed in when we are treating patients with diabetes in different countries across the globe. Now, the topic which we are going to discuss is gliptinization. What are the roadblocks associated with initiating gliptins in an individual, and how do we address these roadblocks? Now, first and foremost, why? Like, since we have chosen a molecule to treat diabetes, why do we need incretin mimetics? And why do we think that they are more suitable for Indian patients? Now, there's one good news for Asian patients is that incretins in Asians are more effective compared to that of the Caucasians. So let us see if how this mechanism of action of incretins in Asians proves to be more effective than in our Caucasian counterparts. Now we see that intact GLP-1 levels are considerably low in Japanese, and meal-induced enhancement of GLP-1 is negligible in the Japanese compared to the Caucasians. However, the intact GLP-1 levels are comparable between non-diabetics and type 2 diabetes, suggesting impaired insulin secretion in Japanese type 2 diabetes patients. The reduction of postprandial active intact GLP-1 in Asian type 2 diabetes patients could possibly be due to increased activity of the DPP-4 enzyme. So since in our kind of a population, we have increased activity of DPP-4 enzyme, hence, a molecule which would inhibit this enzyme, that is a DPP-4 inhibitor or a gliptin, would prove to be more effective in these population rather than in Caucasians who already have it, already have that enzyme activity lower. Now, it has been seen that there has been a correlation between the circulating plasma DPP-4 levels, which correlate positively with the waist to hip ratio, total intra-abdominal adipose volume, liver span, fasting serum insulin, LDL cholesterol, triceps skin fold thickness, and total intra-abdominal adipose tissue volume. So there's increased DPP-4 enzyme activity in Indians with type 2 diabetes, and this activity is even more increased in non-obese Indian patients with type 2 diabetes. When we use a combination of gliptin and metformin, we tend to address a number of pathophysiologic defects which actually lead to type 2 diabetes. Now, we know type 2 diabetes is an intriguing disease in the sense that it is not just one pathophysiologic defect which leads to hyperglycemia and its complications in type 2 diabetes. It's a multifactorial disease. There are a number of pathophysiologic defects, and when we use a combination of a DPP-4 inhibitor and metformin, we address reduced hepatic glucose output. We have moderate activity with metformin in reducing the peripheral insulin resistance, improves insulin sensitivity, and metformin to a certain extent also increases the GLP-1 secretion. when we use a DPP-4 inhibitor in combination with metformin, we see that in addition to what benefits we achieve with metformin, that is improvement of insulin sensitivity, decrease in peripheral insulin resistance, and increase in GLP-1 secretion, we see that with DPP-4 inhibitor addition, what we achieve is an increased insulin synthesis, increased insulin secretion, again, reduced hepatic glucose output, and indirectly it leads to improvement in peripheral resistance, insulin resistance, improves hepatic insulin resistance. It reduces the glucagon secretion, improves the GLP-1 levels, and leads to gastric inhibitory peptide stabilization. So when we are using a combination of metformin and DPP-4 inhibitor, we are addressing, or we are already taking care of multiple pathophysiologic defects which leads to hyperglycemia in type 2 diabetes and its complication. The efficacy of DPP-4 inhibitors, as we just discussed, is higher in Asians compared to non-Asian, and this slide shows the HbA1c reduction in Asians, which is this dark blue bar, compared to non-Asians, which is this light blue bar. So we see that reduction in HbA1c is more profound with DPP-4 inhibitors in Asian individuals compared to non-Asian individuals. When we speak on a broader term, what are the roadblocks for widespread utilization of any anti-diabetic agents in India, not only just gliptins, but when we speak of addition of any anti-hyperglycemic agent in individuals with type 2 diabetes, these are the concerns which we commonly face, that is efficacy of the molecule, the safety, durability, compliance, and of course, the logistics parts is also very important, because in India, patients pay out of their pockets, and hence a molecule being economically improves the compliance, improves the adherence, and helps achievement in the targets, HbA1c targets, which we have. Now, speaking on the first concern is the efficacy of a molecule. Now, when we speak about vildagliptin, in the context of vildagliptin, efficacy is not a concern. It is one of the most efficacious gliptins that we have. In this study, where the efficacy and safety of vildagliptin was compared vis-a-vis sitagliptin, linagliptin as an add-on therapy in Chinese patients with type 2 diabetes who were inadequately controlled with dual combination of insulin and traditional oral hypoglycemic agents, it was seen that there was a good reduction in HbA1c, as we see HbA1c reduction with vildagliptin compared to sita and lina. More number of patients achieved the HbA1c target with vildagliptin compared to sita and lina, and the dose of insulin requirement was brought down significantly by vildagliptin as compared to that of other molecules, other DPP-4 inhibitors like sitagliptin and linagliptin. So what best we can say is that from the various studies, that vildagliptin is a good DPP-4 inhibitor with an efficacy efficacy which is at par, if not better, compared to other DPP-4 inhibitors. Now, vildagliptin is a molecule with an extensive real-world evidence. So in this study, where the initial combination therapy with vildagliptin plus metformin and drug-naive patients with type 2 diabetes, it was a 24-week real-life study from Asia. And in this, it was carried out in 4 countries across Asia, and total of 532 patients were there. It was seen that there was a robust HbA1c reduction with vildagliptin, significant HbA1c reduction from baseline at 24 weeks, and it was statistically significant, up to 4% reduction in HbA1c in patients who had a baseline HbA1c of more than 10%, and around 40% of the patients achieved the HbA1c target of less than 7%. So when we compare the effects of vildagliptin as regards the fasting plasma glucose, it was effective in reducing the fasting plasma glucose, effective in reducing the postprandial blood glucose levels, and it also brought about a minute change when used in combination with metformin in patients as regards their body weight. So at week 12, the body weight reduction was minus 0.6 kg, whereas at week 24, the body weight reduction was minus 1.1 kg. So the conclusion was that in a younger drug-naive Asian type 2 diabetic patients presenting with high baseline HbA1c and often associated with CV risk factors, initial combination therapy with vildagliptin and metformin was associated with a statistically significant reduction in HbA1c from baseline to week 12, and it was maintained up to a week of 24 weeks regardless of the baseline age, BMI, and associated comorbidities. This was accompanied by good glycemic control and weight control. Now, going on to the next issue, which is of concern, is the safety. Whenever we are using any molecule in type 2 diabetes, we are always worried about the safety part, because if we are doing, even if we cannot do good to an individual, we should do no harm. So, vildagliptin is one of the molecules with a proven safety profile in clinical trials as well as real-world studies. The incidence of adverse events with vildagliptin monotherapy was quite less, and they were very mild and insignificant adverse effects like nasopharyngitis, headache, dizziness, upper respiratory tract infection, diarrhea, nausea, and with very less hypoglycemic events. So safety-wise, vildagliptin has a proven safety profile and with insignificant or not clinically relevant side effect profile. In a meta-analysis of 40 phase 3 and 4 vildagliptin studies involving more than almost 17,000 patients, it was seen that vildagliptin was not associated with an increased risk of major adverse cardiovascular events relative to the comparators. In this first real-world cohort study on a nationwide population in Taiwan National Health Insurance Research Database, which had a mean follow-up of 9 months, it was seen that vildagliptin was not associated with an increased risk of CV death, non-fatal MI, non-fatal stroke, or hospitalization for heart failure. And vildagliptin, now, other than cardiac events, the next most important complication, which is very disturbing or which is very relevant in individuals with type 2 diabetes, is diabetic kidney disease or chronic kidney disease in individuals with diabetes. And it has been found that in renally adjusted dose, vildagliptin is safe in CKD patients. Vildagliptin maintained the HbA1c reduction over a 52 weeks period in moderate to severe CKD patients, and overall safety profile is comparable with placebo in moderate to severe CKD. Now, going on to the third concern, we have seen that vildagliptin is efficacious, brings about good HbA1c reduction with a safety profile which is almost similar to that of placebo. The third important concern that is of concern to us is the durability of any oral hypoglycemic agent. And we have seen that vildagliptin has a proven durability in the various trials, of which Verify is one of the recent trials which stands as a proof to the durability of vildagliptin. Now, we know metabolic memory and glycemic legacy are of very important, are of great importance in individuals with type 2 diabetes. And we have seen that in UKPDS and VADT, that initial early and sustained glycemic control is the key to avoid complications at a later stage. So if there is initial and sustained glycemic control, we tend to avoid the bad metabolic memory which builds in the initial few years of bad glycemic control, so that even when we start good glycemic, achieving the glycemic targets after a period of years, the patient has already a bad glycemic legacy which drives the complications despite good glycemic control at a later stage. And we know good glycemic control is something which is rare in India, and one of the reasons for this bad glycemic control, or for most of the Indians not achieving the glycemic targets, is the sequential treatment approach, which is compounded by substantial inertia to timely intensification of therapy. So when we have a sequential approach, what happens is that we have a roller coaster kind of a glycemic control. So we have periods of good glycemic control, and then the glycemic control deteriorates. When we become proactive, add a second agent. So this leads to a bad glycemic memory. However, when we strive for initial, early, and sustained glycemic control, we tend to bring down this bad glycemic memory or metabolic memory. So the improvement in glycemic levels are there from the initial stage, and this in turn leads to avoidance of complications at a later stage. And the Verified trial stands as a robust scientific evidence to back up this notion. So we know Verify, which came out very recently, it's a multinational multi-ethnic trial where the combination of metformin and vildagliptin was used in individuals having an HbA1c of more than 6.5%. And it was seen from this verified trial that early combination treatment half the risk of time to initial treatment failure versus monotherapy strategy. What happened is that when we speak of this primary endpoint, that is time to initial failure, the green is the use of metformin alone, and the blue dots stand on the combination of vildagliptin and metformin. So time to initial failure was quite early with metformin monotherapy, whereas that was deferred for quite a certain extent with the use of a combination. Similarly, time to second treatment failure was also later in case of combination therapy rather than metformin monotherapy. And median time to failure was 3 years in initial monotherapy strategy compared to over 5 years in early combination strategy. When all patients were receiving combination therapy, the risk for time to second treatment failure was reduced by almost 26%. Both the approaches were safe and well tolerated. So coming to the fourth issue, which is of concern to the treating physician, is the compliance on part of the patient. Now, when a patient has to take lesser number of tablets for a lesser frequency, there's always an improvement in compliance. And we now have vildagliptin in sustained release formulation, which improves the compliance. OD dosing was found to be associated with significantly better adherence rates compared to BID. And this concept of vildagliptin 100 OD dose is actually not new, and it was there since the concept has been there since quite some time, and we have published reports to support that. Patients were randomized to receive at week 0 to receive vildagliptin 50 twice a day or 100 milligram OD. And it was seen that vildagliptin 100 milligram OD was comparable in efficacy and safety, similarly effective and well tolerated as the 50 BID dose regimen. And with the 100 OD, the patients were more adherent or more compliant with the treatment therapy rather than the BD dosing. The sustained uniform release of vildagliptin over a period of 24 hours was seen through technological breakthrough in the vildagliptin 100 SR formulation. So this is the high gel matrix technology, which leads to sustained uniform release of vildagliptin from that sustained vildagliptin 100 sustained release formulation. And there's a comparable PK/PD data for vildagliptin 100 SR vis-a-vis 50 BD. And coming on to the fifth issue, which is of concern to us, is the logistics, that is the cost of therapy. And with vildagliptin available now as an SR 100 formulation, and also with vildagliptin losing its patent and a number of companies coming up with vildagliptin formulation, vildagliptin has become one of the most cost-effective gliptin in India. So to summarize, gliptins are more suitable for Indian type 2 diabetes patients and achieve higher glucose lowering efficacy compared to Caucasians. Partners well with conventional therapies, it can be used across a wide number of oral hypoglycemic agents, or it used in combination with any regimen of insulin therapy. It is one of the most extensively studied gliptins in terms of its clinical utility. Vildagliptin remains one of the most efficacious gliptins when compared to other gliptins in the fray, and it achieves higher HbA1c reduction if the baseline HbA1c is high. There's no excess risk of hypoglycemia. It is weight neutral. It is neutral as regards the CV safety. And we have the verified trial, which is the first study to actually show the long-term benefits and glycemic durability of an early combination treatment strategy with metformin and vildagliptin compared with the current stepwise or sequential therapy in patients with newly diagnosed type 2 diabetes. Sustained release formulations of vildagliptin may further improve the patient compliance and thus help reach the glycemic targets for more and more number of Indian patients who have to pay out of their pockets, and the low cost would go a long way in improving the compliance and adherence in Indian patients. So now with that, I would like to thank you for the patient hearing. Thank you.
Thank you so much, Dr. Nilakshi. That was indeed a very nice and comprehensive lecture. There are no questions in the chat box, but I would like to ask you a question. Although not directed to be used in that way, there are many practitioners who use vildagliptin 50 milligrams OD and the rest of the day is covered with metformin. So what is your opinion and experience on this matter?
Yes, ma'am, that's a wonderful question which you have brought up. And actually, that is a widely prevalent practice also. Even me in my clinical practice, I tend to write vildagliptin 50 OD in patients it once a day, or in those patients where I am scared of hypoglycemic events. So even with a 50 OD dosing, it is efficacious in certain individuals whose requirement is less. And that has also been seen in studies where a reduced dose of 50 OD was used in individuals having chronic kidney disease, and it proved that the glycemic efficacy or efficacy as regards reduction in the glycemic levels was good with even vildagliptin 50 OD.
Right. Yes. So because a lot of practitioners use it that way.
Okay. Yeah, I also use it
right.
times in certain patients. Yeah. And that is sometimes even vildagliptin metformin 50-500 combination once a day. Maybe that is also effective in certain patients, because every patient differs actually. Some patients would have a normal fasting level and only their postprandial glycemic levels would show excursions. In them, perhaps giving a vildagliptin 50 with metformin once a day before breakfast would help control the glycemic levels throughout the day.
Right. Thank you. Thank you so much, Dr. Nilakshi. Thank you very much for this talk. And thanks for being a